Well, welcome everybody. We'll make a start. There'll be one or two people drifting in, I'm sure, but we'll make a start now so we can finish on time for the plenary. So welcome. My name's Ian Watt and my colleague Vikki Entwistle. I'm from the University of York and Vikki's from the University of Dundee. And our aim today is to go through some thoughts based partly on our own writings, but also partly on some studies that we've both been involved in, looking at patient engagement, patient involvement. So let me just first of all run through the aims of the session. And Vikki and I are going to mix and match the presentation. We've all, in the back of our heads somewhere, got slides that we're both going to speak to, and it should just run seamlessly as we jump from stage to projector. That's the idea, but you'll probably find us kicking each other at various points to get off the computer and leave it for the other one. So, as I say, the aim is to look at some of the current ways of thinking about involving individual patients in their care. And we're going to look at that in two main areas. We're going to look at it, first of all, in decisions about their own health care. And then secondly, we're going to look at patient involvement in attempts and efforts to improve the safety of their care. And we're going to look at some of the complexities that can arise in these situations. So I should say right at the outset, this is certainly not a rejection of patient engagement. In any sense, we are both great advocates and supporters of patient engagement in healthcare. But what it is an attempt to identify some of the complexities and potential solutions that may help the adoption of patient engagement and improve patient care. So in terms of the outline, introduction, what I'm doing now, and then we're going to take the session in two halves. We're going to, first of all, look at individual involvement in decision-making around individual decisions about people's care. And then we're going to take the safety aspects in the second half of the session this afternoon. And for each area, for both involvement in decision-making and involvement in safety, we're going to, first of all, look at some of the prevailing ideas about involvement. And then we're going to discuss some concerns that we may highlight about them, about the prevailing ideas, and then we're going to discuss some of the alternative ideas. So that's the background. I'm going to hand over to Vikki now to say a little bit more.
Thanks, Ian. We did say to each other that we would chip in with the bits that we respectively forgot to cover. So I'm going to just chip in and say we should perhaps say that Ian has a background as a general practitioner, so he has some clinical experience. I have absolutely no clinical experience. I come from a more social science philosophy background. We've been working together for a while, so we'll do this kind of thing, pick each other up, I guess, as we go through. As Ian said, focuses on the involvement of individuals, and we are starting from a position that involving individuals in various ways in their own care is generally a good thing. And there are two main reasons for thinking that it's generally a good thing. We can think of it as both just the right thing to do intrinsically. Patients are persons, patients are people, and we think they have rights or should have rights to have options to influence decisions and actions that affect them. The other main cluster of arguments for saying that patient involvement, involving patients in their own care is a good thing, is that it has good consequences. It tends to, it can be seen as an instrumental means of improving things that we think are good outcomes. That might be health-related outcomes. It might be about reducing costs. So that kind of way of thinking is, in part, encourages thinking of patients as resources within health services. And in principle, in general, both of these arguments, I think, are okay. But there are, as Ian said, complexities. There are some ways of thinking about them that are perhaps less helpful than others when it comes to practical details, and there may be tensions between them. So it's those kind of things we're wanting to explore, but we're not critiquing the overall general principles. And we're going to focus first on the idea of patient involvement in decision-making. And at a number of points on our slide, we were encouraged to make this a workshop kind of presentation. At a number of points in the slide, you'll see bubbles, little kind of blue thought bubbles with questions in them. And they were going to be the points at which we might rove around with a mic and get people to engage. Second, plan B was that the points at which we would ask you to perhaps turn to your neighbour and have a couple of conversations, but you're so scattered across the place, there are individuals around. So I'm just going to encourage you at this point. We will, for a few of the bubbles, we will have a go with the roving mic, so please be prepared to engage, critique, participate. Otherwise, and I know everyone's getting a bit tired, but when you see the blue speech bubble, try and start to think about, well, you know, how would I answer that question? You won't necessarily have the best possible answer. You might have a really well worked out one, you might have never thought of it before, but just try and, if we're not going to engage in discussion all the way through, engage in your head and think how would I answer that question. So if we start with thinking about, okay, why is patient involvement in decision making important? And those general principles that we had on the back slide, on the previous slide, for why is involvement important in any kind of context, start to suggest some answers. And some of the common reasons we hear for thinking that it's important to involve patients in decision-making about their own healthcare is it's important to respect people's autonomy. That maps onto that first general thing. It's generally the right thing to do. We might also think, particularly when we know that, or from a clinician's perspective, you might think, actually, there are several good options for treating this particular condition that this patient has. We think that involving patients in decision-making can help promote individually appropriate care. The person gets the care that most suits them. That might also reduce waste. It stops giving surgery to people who really don't want surgery. It stops prescribing medicines to people who won't take them, and so on. Another reason is that if patients are involved in the process of thinking about decisions about their care, they might better understand the treatment options that they eventually have, might be better placed to know how to take medicines more appropriately or to recognise problems that emerge and so on and so forth. So there are a number, these are just a few, but there are a number of good reasons for thinking about involving patients in decisions about their own care. Next question, so what should it look like? What does it look like in practice to involve patients in decisions about their care? And you'll have all be familiar with a number of examples, a number of different forms. But the particular way you tend to think about, well, what should it look like, might reflect to some extent your views about, well, why do I think it's most important? And if we emphasise particular reasons for involving patients, we might also be inclined to favour particular models or approaches to involving patients. And what we're going to do in this session, the next few minutes, is focus on, if we think of the reason, if we think that it's important to involve patients in order to respect their autonomy, what does that imply about what patient involvement in decision-making should look like in clinical practice? Yeah? And I'm going to start with a fairly conventional view of what it means to respect autonomy. A model of respect for autonomy that I think is taught to a lot of clinicians, certainly a lot of medical students. Standard medical ethics, it's a view of respecting autonomy that focuses quite strongly on the idea of respecting patients' autonomous choices. And it basically goes, if patients are competent, so we're not talking about young children, we're not talking about people with learning difficulties, we're not talking about people with quite severe dementia, for example. If they're competent, then health services and staff should respect their autonomous choices in a kind of and respect here is in a kind of stand back and don't interfere too much way. Where autonomous choices are understood as choices that we think about and make deliberately. We're not talking about just habits or things that people do without any thought at all, but things that they think about, and that these, to be autonomous on this theory, the choices should be informed, so the patient, to make an autonomous choice, must have some degree of understanding, and they must be substantially free from controlling influences, so the person isn't making this choice under duress or under undue pressure. Is that a view of autonomy, respect for autonomy, that some of you are familiar with? Yeah, a few nods in the audience. Okay. well, what are the implications of adopting that view of respecting autonomy for thinking about how to involve patients in decisions about their care? Well, it seems to imply that to involve patients in decision-making, what clinicians need to do is inform them about options, so that they understand, that they are able to make decisions with understanding, and then to elicit and respect their choices, or their preferences is often how it's talked about. And there might be a partnership or discussion, so a lot of the conversations about shared decision-making stress the importance of working as partners. But there's also quite a clear division of labour implied by the model, which is that the clinician brings their professional knowledge about the treatment options that might be reasonable and the outcomes, the research-based knowledge about the outcomes of those options, and the patient brings knowledge of their own personal circumstances and situation, what matters to them and their preferences. Is that a model of involvement that sounds familiar? Okay. It's a bit abstract, so Ian's going to now talk us through a more concrete example. Might be a bit simplified, but concrete example.
Okay, so as Vikki says, I'm going to go through a very simple scenario. We've chosen the area of a patient with an abdominal aortic aneurysm. It could be a number of conditions, but we're just using this for purely illustrative purposes. And in many ways, I've grossly simplified the scenario. So we have a patient, imaginatively called Mr. A. And Mr. A has got a aortic aneurysm. He goes to see the consultant, the specialist, and the specialist tells him that he has two main options for treatment. He goes through quite reasonably with the patient. He goes through the sort of pros and cons of each option, and he goes through what each option would involve. Basically, it's a choice between open surgery and an endovascular repair. And the consultant then goes on to ask which option Mr. A would prefer. So that's a very simplified and abbreviated scenario. But again, taking Vikki's questions, is something that you would recognise. Would you see this as being a good example of involvement in decision-making? The consultant has run through the options, he's explained them in a bit more detail, and asked the patient what their preference would be. Okay, so let's just move on a little bit. So still in the clinic, Mr. A admits that he really doesn't know which option would be the best. And he asks the consultant, the specialist, he asks, which one would you recommend? The consultant is a bit more equivocal and says, well, really, it's the patient's choice. Both are reasonable. They have different risks and benefits attached to them in terms of survival, in terms of complications and recovery rates. And it's really down to Mr. A to choose. And if Mr. A wants, the specialist can give him some information, point him to further information, go away and have a think about it, and let the consultant know later. So again, just leaving him to make the decision. In many ways, you could argue that this is respecting the patient's autonomy. But Mr. A is still a little bit unsettled by this, so he leaves the consultant and then goes to visit his GP. And he tells her what the consultant has told him and said that he's really undecided. In fact, worse than undecided, he's really quite anxious about which way to go, and he's becoming increasingly stressed about the decision and the choice in front of him. And perhaps he's thinking maybe he shouldn't have the repair at all. And so Mr. A asked the GP what she would do. The GP acknowledges that it's a very difficult decision, but really it's best for Mr. A to make the decision. She's different, she's got different views and preferences, and really it's better if Mr. A comes up with his own mind. The GP says she really wasn't that very well placed to advise. So, another question for you. How well do you think Mr. A has been involved in decision-making? If we were to judge this as a case of involvement in decision-making, how would you gauge it? Do you think he has been involved in decision-making about the management of his aneurysm? Is there any further information you would like before making that decision? What else could have been done? What alternatives may have been followed? So just have a little think about that yourselves. If you want to turn to your neighbour, good time to introduce yourself now, and just have 1 minute. That's all we're doing. We're at 4 o'clock now. We just take a minute just to think about that. Just turn to your neighbour and just have a think about some of these. And then we're going to try and canvass some opinions about this, and we'll come around the room with our mics.
Oh, well, look, people talking. So shall I just go and do a...
Look, I can go around if you want. Do you want to stay here?
Yeah, just okay. And if people want to go to the mics up there, then...
You're the next one.
Yeah, perfect. Thank you.
Okay, that's great, thank you. So I'm just going to come round now with the mic, and really, if you've got any points that you'd like to make, we're going to have questions at the end of the presentation, so that's fine. But really, with respect to that question, has anybody got a point they would like to make? Okay, there's one over here.
There's one thing missing. Before entering in this conversation, the consultant should ask Mr. A, which kind of decision involvement do you wish? Do you want the consumer's point of view so that I lay out all the information, you make your independent choice? Do you want the paternalistic way, I tell what's best for you? Or do you want shared decision making? So without having this agreement between service provider and service user, you're out on a thin ice, ethically speaking.
Okay, thank you. So that's a point about, should there be a sort of meta decision before we even get into this about the degree of involvement that a person should want. Any other points? So there's one here.
Yeah, there's a couple of things, but the particular one was although we know his age and we know he's male, we don't really know anything about Mr. A. We don't know what matters to him, where he's coming from, whether he lives on his own, what the implications of surgery might be for him. Yeah. So we lack, they may have all been discussed, but we lack an understanding of his prior position, his prior knowledge about this, anything that is personal to him in this.
Okay, so that's a point about, again, we've given deliberately in many ways a lack of information to allow Mr. A to have a care program that's individually tailored to him. One more final point and then we'll carry on.
I'd probably like to make 2 points. One is that the fact that nobody's willing to sort of make a decision or suggest a decision, I think, would make the patient a little bit suspicious that perhaps there's something missing. So I think that's very important. And also, I think it becomes very impersonal. Here's all the facts, decide. It becomes, there's no warmth there. There's no, well, don't worry, it's going to work. This is probably a little bit better, I think, given your condition. Some paternalistic advice. So patients expect that, I think.
Okay, thank you. That's really helpful. I'm sorry we don't have time to get everybody's contributions, but hopefully it gives us a flavour of some of the issues to consider.
Thank you very much. And of course, we had to try and pre-guess some of your responses, and we put down some other ideas that certainly, even between them, aren't the whole story themselves. But we're thinking about, okay, so that scenario and some of the points that you've picked up start to illustrate some of the limitations of thinking about involving patients very strictly in a model of respecting autonomous choices. Although some of the points you've raised, I'm jumping ahead too far now. Do you want a bit more of the scenario first? Sorry.
Okay.
A little bit of muttering amongst ourselves.
I told you that it would be seamless, the way that Vikki and I would float from slide to slide, and we're proving that point. But if we sort of consider how the doctors might be thinking about this, both doctors saw Mr. A's difficulties, but were feeling a little bit uncomfortable about them. They still thought they shouldn't have helped Mr. A further with the decision, because they reasoned and that they were really wanting to respect his autonomy. That was their overriding influence. We must inform him, but shouldn't interfere with his preferences. That was the kind of way they were thinking. we might also add that the GP may also have been thinking in her mind as well that she really didn't know too much about abdominal aortic aneurysm repair. But that's a separate issue.
Thank you. Sorry, we'll continue now. So there's a similar set of questions, but just from the doctor's perspectives, that we might ask, OK, were the doctors right to think they shouldn't have helped Mr. A any further? Were their actions appropriate in respect to thinking about his autonomy? They certainly fitted with that the model that we looked at. That's how we constructed their position. But are there ways that we could think, could they have been both more helpful to Mr. A, who was struggling with the decision, and been appropriately respectful of Mr. A's autonomy? And I think, for me, these scenarios highlight some limitations of current ways of thinking that tend to kind of surface quite a lot when we're talking about involving patients in decisions about their own healthcare. And just to summarise some of those limitations, giving a menu of options can be very, very important. But I think sometimes it's overrated in terms of what it can achieve in respecting people's autonomy and enabling people to be autonomous. The current model of thinking, certainly that way of thinking about respecting autonomous choices, seems somehow to obscure the complexities that arise if we recognise that people's abilities to make decisions vary. And often just giving information about options and their outcomes isn't enough to enable people to participate in a meaningful way. People might express preferences, but they might not be very confident about those preferences. They might struggle to identify a preference, and their preference might be based on thinking about putting a lot of emphasis on one issue and forgetting to think about another. They can be problematic. You know, patients' first expressed preferences aren't necessarily going to lead to the decision that is best for them without any further exploration. The other problem about that kind of the emphasis on that focus on autonomous choice and stand back, respect, don't interfere with patient preferences model is that clinicians who try to avoid influencing patients, like the two in our scenario, just might not provide sufficient support to enable people to participate. And when clinicians, like some of those in the audience who've expressed concern about or seen some of the limitations of what the two doctors in the scenario did, will have seen they might be inclined to give more and different kinds of support. But on this model of respect for autonomy, on the conventional model, it's not clear how we can assess those forms of support for appropriateness. Are they becoming badly paternalistic? Are they, what's going on with those things? Our current way of thinking about respect for autonomous choices doesn't really allow us to differentiate well between different forms of support. A few years ago, Ian and I were thinking about the idea of involvement in decision-making and recognising that this notion of involvement as informing people and letting people choose felt a bit thin. And so how do we think a bit more broadly about it? And we were also a bit aware that people have their own pet models of how to involve people in decisions about their care, and our thinking and our ability to engage in conversations with other people in healthcare about them was perhaps a bit limited if we focused on thinking about patient involvement in decision making. So perhaps we should think about a completely different context. And when you look at the kind of answers people give to questions about was someone involved, you can start to see the richness of the idea of involvement. And hopefully we'll do this now with our bank robbery example. So we started thinking, I don't know why we started thinking about a bank robbery, but we did. And we're thinking, so we're encouraging you to think, OK, who would you say was involved in a bank robbery? And in what senses do you think they were involved? And the characters might include the leader of a regular criminal gang who has the inspiration for this robbery, is the mastermind behind it, coordinates the whole thing, gets everyone engaged on board, planned, and etc. Well, he's pretty clearly involved in some sense in this bank robbery. And what about then the gang member, who kind of is a bit of a follow-the-leader gang member, but feels very much part of the gang, belongs to it, gets the job of driving the getaway cars, really, really pleased to have that. Or another gang member who has a few more brains about him and is assigned the task of getting a job in the bank, so they've got an inside member. How's that person involved? And they're all involved in the gang, and they're all involved in the activity of the bank robbery somehow. bit of a way into the planning, and they identify, oh, none of us knows how to get into the safe. So they co-opt a locksmith, a safe specialist, who at first kind of signed up to the enterprise, but is a bit uneasy with the other gang members to start with, although he gets more familiar with them as time goes on, and he locks the safe. Fairly kind of crucial contribution to the robbery. How would you say that person was involved? Was he involved as much? Was he involved to the same extent, in the same way as the other people who contributed to the robbery? What about the bank staff? Were they involved? One of them perhaps was assigned the task of inducting or leading in training the person who, unbeknownst to them, was actually a member of the gang who was getting involved, was coming to work in the bank, so they had an inside member. That person gave away secrets inadvertently, contributed to the robbery inadvertently. Were they involved? How were they involved? Bank customers on the day, held up at gunpoint, gagged, handcuffed, put into the back room for a bit distressing. I'm sure some of them would say they were involved in the bank robbery, but clearly not in the same way as the gang leader, the gang members, and so on. Gang leader's mother, she's a bit of a construct here, but a nice little old lady, got all her wits about her, but completely bedbound. Couldn't participate in any of the gang meetings, couldn't do anything on the day about physically contributing to the robbing of the bank, but was really, really pleased because her son kept confiding in her the plans, how the progress was going. She was quite excited. She was really rooting for them. You know, she felt really privileged to have been involved. She felt involved in it. She might not have done anything, but she felt involved. And so hopefully, I mean, you could think a bit further, and but hopefully what that does is just starts to open up. There are lots of different ways in which we can talk about and think about people being involved in things. We can think about being involved. I had to put the about involvement there because when we submitted this to a journal for peer review, and someone said, could you make explicit that you're not drawing an analogy between bank robbing and healthcare? Anyway, sorry. But what it did draw out was people can be involved in activities. We can think of them as being involved with other people. Being involved in terms of kind of taking part, doing actions is important, but people can also be involved by virtue of what they think and feel, how they identify with something, as well as by what they more visibly do. So involvement can be more or less actively sought, it can be more or less welcome, it can be more or less visible to others, it can be more or less influential. It can vary in lots of domains, and some of those might be important and useful for thinking about the ways in which people are involved in decisions about their own healthcare. I'm just checking this to see at what point I hand over to Ian. Okay, I carry on here. Right. Okay. We also thought in terms of broadening that it might be worth thinking of broadening about the activity of decision-making that we think of people as being involved in or not. So the current model, the model that kind of draws on that respect for autonomous choices, tends to focus on people's involvement once they've been given a menu of options in appraising those treatment options and choosing one of them. But as this slide tries to show, that activity is located in a broader problem recognition, problem solving cycle of decision making and review. And patients might be involved in any number of those processes, and indeed being involved in some of the earlier ones, like recognising and clarifying a problem and identifying some possible treatment options, might have knock-on consequences for how they can be involved in next stages. So it's worth thinking about involvement in that broader range of activities. So hopefully by this point, you're kind of agreeing with the thought bubble at top left, which is that, actually maybe we need to think reasonably broadly about involvement in decision making. The question that I think we've still got is, even if we think these broader forms of support from clinicians to facilitate broader forms of involvement in decision making by patients seem good, how can we justify them? What kinds of support can clinicians justifiably offer if they want to claim to be respectful of patients' autonomy? I think I still keep going. Stuck with me for a minute or two longer. Okay. There are alternative ways of thinking about autonomy than focusing on autonomy, respect for autonomy as autonomous choices. And I think the basic idea of, well, what is personal autonomy? What is this thing that seems to matter to us, that we seem to care about, that we think patients care about? The basic idea of personal autonomy is something like being able to be our own person, to shape our own lives, as opposed to living under the control, the oppression of other people. There's something about that being our own person, shaping our own lives. But, of course, well, part of the reason we think it's important, but the context in which we think it's important, is that we're socially intertwined human beings. You know, we can't escape social influences, historical and contemporary, close to us and further afield. So we're in a web of a changing web of interpersonal relationships, broader social structures. We live in societies with overlapping cultural norms, sometimes conflicting cultural norms. And all of these influence our preferences and our actions. So when we're thinking about what it might mean to have personal autonomy, we have to take seriously the question of how and why do different particular social influences, because there are lots of social influences, help or hinder our abilities to be our own person, live our lives in our own way. And the notion of respecting autonomous choices that we saw earlier kind of doesn't seem to deal with that stuff. But there are alternative relational accounts of autonomy. There's a whole cluster of them. Philosophers have been struggling with this problem of how can we meaningfully be said to be autonomous, given that we're socially intertwined in a lot of ways. And basically, what they have in common, these cluster of accounts of autonomy, is that they take social context seriously. Sorry, the bullets are a bit long on this one, but the first one is basically they treat social context as significant. And the accounts vary. There are different relational understandings of autonomy, but broadly, they don't focus on, well, what preference do people have? They don't view what individualizes people as their different preferences. They focus particularly on, or they pay attention to, what capabilities do we have? How are we able to be our own person and shape our own lives? And so between them, they encourage just a richer set of, more nuanced set of way of thinking about what matters for people's autonomy. And they encourage us to attend, for example, to the motives of people who do and who try to influence us. They pay attention to power relationships, or the power in relationships, to people's capabilities, the relationships between capabilities and responsibilities, to thinking about what matters for people's identity, issues of ownership of decisions, issues of authorization of decisions. So they allow us to think in a broader range of ways. I think I'll hand over to Ian.
With that in mind, let's just revisit the scenario that we had before. So, as I've said, relational accounts can include, if we take a relational account of autonomy and use that as our framework, then there are a number of implications that flow from that. We can include people who may be considered less competent, for example. It does not imply that anything beyond informing is necessarily inappropriately influencing. And they, in terms of judging whether or not an interaction or a relationship is supportive of autonomy, if you follow a relational model, then it does suggest that situation-specific judgment is needed. So in terms of revisiting the scenario, Mr. A still has his aortic aneurysm. He's still informed by the specialist about the two options. He asks Mr. A what he thinks about those options and whether he has any questions. And Mr. A says, well, he knows what an aneurysm is now, and I think he does think that probably something should be done about it. And maybe the overall survival rate is making him think that endovascular repair would be the better option, but the complications sound worrying to him. Well, the consultant says that that's probably a sensible path to go down, that he tends to favour the endovascular repair as well himself. But he's right to be concerned about possible complications. and he outlines the main kinds of problems that could arise, but also importantly, he details how they could be dealt with. The consultant asks about his family and the work situation. They discuss what kind of support he may need after an operation. Consultant again asks what Mr. A is thinking now. And Mr. A agrees that, yeah, the endovascular repair does seem to be the way to go. Consultant again reaffirms that decision, says he will book him in for surgery, but still gives him further information, asks him to discuss it with his family, and come back to him if he has any concerns. Clearly, there's a lot more detail in that scenario, but the distinction there is that Mr. A has certainly been involved in the decision by some of the accounts that we've looked at in terms of the bank robbery scenario, but he's also been very supported as well in his decision-making. So, a question for you, which I'm afraid we probably won't allow any time, but something for you to think about. How well do you personally think, and maybe we can come back to this at questions at the end, do you think Mr. A was involved in decision-making about the management of his aneurysm? And if you were to make a judgment about this, we've already heard from some of you that you would like more detail. If you were to make a judgment about the quality of that involvement, what else would you like to know? And I would argue that there are a number of things that you need in terms of forming an assessment of someone's involvement in decision-making about their care. Some of them are more easily assessed than others, but it would be good to know the clinician's motives in the communication. Is this something that the clinician is trying to support the patient in whatever model of autonomy they have in mind, but also support them in achieving what's important for that person? What are the patient's specific needs for support? Were they met? Each of us at various times in our lives have different needs and needs for support. Were they met at this particular time in this situation? What were the patient's particular concerns and interests at this time? And how well were those concerns and interests identified and addressed? So there's a number of things there. I won't read through the rest of the bullets, but there are a number of things there. We would argue, it's not an exhaustive list, that it's really important that we have insights into if we're going to make assessments of the quality of someone's involvement, and which makes the whole process of researching this, of auditing it, of trying to record it to improve the patient experience, really quite challenging. So I'm going to leave that there for now. I'm going to move on to, I said, one of the other things we would like to do this afternoon is to look at patient involvement in improving their own safety and enhancing their own safety. And the prevailing ideas around this are that patients can and should have a role in contributing to the safety of their own care. And when it's their own individual safety, there's probably two main ways they can do this. They can do this by helping inform their clinicians about their management, by discussing any allergies they may have, by being as open as they can be about their particular concerns, about their symptoms. So there's a number of things they can do to help inform their management, but once their management is underway, patients can also play a very active role in monitoring and ensuring that their treatment is safe. And there's been a number of ways that's been achieved by encouraging people to speak up if they are approached by a clinician who hasn't washed their hands, for example, by checking that the medication that they're being given is the correct medication for them. A number of things there. But patient involvement, it's fair to say, many people do recognise has limits as a strategy in and of itself, and many patients themselves will admit, as we've seen in some of the presentations over the last few days, that whilst they're happy to be involved, they don't want the system to rely upon those as the final check in terms of improving the safety of their care. So what I'm going to do now is I'm just going to share with you some quotes just to illustrate a number of the concerns and complexities around this strategy of patients being involved in the safety of their own care. And these quotes come from a piece of work we did a couple of years ago now, where we interviewed probably about 100 patients and undertook a number of focus groups as well with people from a diverse range of conditions about their views on patient safety, their views on the appropriateness of patients being engaged in safety and their own experiences of being involved in the safety of their care. So this first quote comes from a man in his 70s who was in hospital following a hip replacement. And as he points out, they came to give me an insulin injection, which was a complete mistaken identity. And had I been feeble or semi-conscious, I don't know what would have happened. But I was compos mentis. He was alert enough to say, on your bike, you're not going to give me an insulin injection. And as he says, a nurse later came to him and apologized that she'd got him mixed up with a patient with a similar name on the ward. So this is an illustration, if you like, of how patients really can perform that safety function through involvement and being able to speak up. We also, as I said, we did this across a range of conditions, and one of the groups that we spoke to were people with mental health problems, and I report here just some quotes from a focus group that we ran. So one of the patients in that focus group, so it's not easy speaking up about concerns about your care. Also, just identifying a concern that they might be picked upon if they were to start complaining. I think if you complain, your number's marked and you're a difficult patient. And there was a broad range of agreement with that comment within the group. But then one person said, well, I've had a fear of that, but probably due to my experiences in a hospital where I used to live. I've recently moved to another hospital, and I was actually more relaxed with the staff. So probably would be heading towards the easier end, that this person's saying now they've moved hospitals, it's actually easier for them to speak up. But reflecting the attitudes of the staff can have a major impact. Another patient said, I actually found it became quite easy because the staff was so approachable and positive. It wasn't a question of complaining, more one of bringing things to their attention that I thought they should know. So again, great emphasis within these quotes of the importance of the staff reaction and how people are concerned about how they might be perceived by staff. This next quote, we put there professional. She was a health professional, this woman that we interviewed, and she'd had surgery for breast cancer. And I've put it down that she was a health professional, just to illustrate the point that even for people who may have a high degree of health literacy and familiarity with healthcare, there are still challenges in speaking up about concerns about your care. So this woman says, I tried to challenge somebody when they didn't use some hand gel when they came to change my drip. But I made such a hash of it. She was really concerned that she really got it all wrong. And she would try to say, it says in the notice that I can challenge you. And the nurse misunderstood her, brought me some hand gel, and still went ahead and did me. He brought the hand gel for her and didn't use it himself. And I thought, I'm not going to ask again. I tried. I got it all wrong. I obviously didn't express it in the way he understood. I could see he hadn't used any hand gel. He was rushing here, there, and everywhere, but I blurted it out in a way he didn't understand, and I felt too embarrassed to say, no, that's not what I meant. So here's someone who is still familiar with healthcare surroundings, but really is just concerned and just doesn't feel able sometimes to speak up because of this fear of embarrassment. Tried it once, but it didn't work out. And another health professional who'd been in hospital, she came back to the ward because she was concerned about a possible infection. So I'm just sat there, and time went on, and you could see how busy they were, and then you start to think, is it really that bad? And then again, you began to query that to yourself, really starting to doubt whether or not her concerns were really valid, whether they were important, and whether or not they were something that she should speak up about. Also mentioned, she didn't feel particularly great that day. This was a day where she felt unwell, and it does take a degree of personal energy to start to speak up about concerns about your own safety. And on this particular day, she really was at a low ebb. So start thinking about, well, what do health services and staff need to do to support patients' involvement in improving the safety of the health services they use? And again, I'm just going to leave that question there for you to have a little think about. We focus on patient involvement in safety on the patients, but we also need to think, what do health services and staff need to do to facilitate that? So thinking about patient involvement in safety, what are some of the problems that we encountered in the research that we did? Well, firstly, while people were broadly supportive of the notion of speaking up about concerns, there was a fair agreement that this was a generally hard thing to do. And that often people felt very uncertain of their ground. They felt that really to raise a concern, you really need to be a bit more certain of your grounds for those concerns. And a number of the hospitals where we worked in had posters up. In other hospitals, staff have worn badges saying, please ask me, please speak. If you have a question, it's okay to ask. And that formal permission may be helpful, and it may be necessary, but it didn't seem from the interviews that we were doing to be sufficient to encourage people to speak up. Because when staff seemed busy, or it came across as being uncaring, or through their actions and their words seemed unwilling to involve people in their care, it was very difficult then for people to speak up. And patients' inclination and ability to speak up about concerns did seem to be strongly influenced by staff behaviours. And I'll give you one additional example of that. There was a lady who was on a chemotherapy ward who was sat in her bed, and all around the ward were rejoinders to people that when they went home, if they had any concerns about any side effects they were experiencing, just to ring the ward. And yet she witnessed how busy the ward staff were, and she also witnessed that when people did phone, because she could see the nursing station with the phone on, that when people did phone and the nurses put the phone down, they were often very dismissive or actually quite rude about the patients who just phoned. And that really made her think twice about wanting to phone once she'd gone home. So I'm going to hand over to Vikki now for another sort of discussion of some of the ways you could approach these concerns and these limitations. And so Vikki's going to outline what we're calling capabilities thinking.
Thanks, and I'll keep it brief. I think what some of the, as I think a number of the projects that I've heard about during this the course of the last few days recognise, there are limitations to approaches to encouraging people to contribute to their care, to get involved in promoting their safety by simply just telling them to speak up. That's hopefully what these things have illustrated. And what we're interested in, what we're starting to explore is, well, just how can people be enabled to contribute to their care, contribute to their safety, be involved in their safety. And there's a body of thinking that was developed, there's a capabilities approach, which has emerged in work on global human development, issues of extreme poverty, kind of social justice type thinking. And there are some concepts and ideas from there that could be quite useful to import into healthcare in a number of ways. And I think particularly in this, certainly in terms of supporting self-management, but particularly in this context, in thinking about how can we enable people to be involved in ways that allow them to contribute to their safety. And basically the key idea is that there's something that matters about being able to be and do what we value being and doing as persons. And this is reflected in one of the recurring themes of the conference by asking people what matters to you. What does it matter to you to be able to be, to be able to do? Thinking in a safety context, I think we can use it as well. So let's focus for a minute on the extent to which people have capabilities, which we think of as genuine opportunities, genuine freedoms, powers, capacities, abilities, to be able to be and do what they value being and doing. I think, for most of us, well, if I'm able to contribute to the safety of my care, good reason to value being able to contribute to the safety of my care. And one of the key things about this idea is that, a bit like the relational understandings of autonomy, which encourage us to think about how are people enabled by their social circumstances and their relationships, how are they enabled or disabled to be their own person, do their own thing, to what extent are people, how are people enabled or disabled by their environment to contribute, in this case, to their healthcare safety. And it recognises that our capabilities, the kind of capabilities that get talked about in general, might include capabilities to be well nourished, to be free from exposure to infectious diseases, to be able to engage in meaningful activity or work, to be able to form meaningful relationships with people and be respected by others. So there's lots of different capabilities, but one of the features of them that we need to recognise is that our capabilities are dynamic and socially shaped, and they're also situationally specific. So I have quite a capability to get around on public transport and read signs and find my way around when I'm in an English-speaking nation. When the signs are written in English, I can read and just about understand English. I come to France and I get by, but I might get a little bit more lost than I would otherwise, and I would struggle if I needed to ask someone for directions and got a very fast verbal response. I'd be a bit stuck. If you put me in China, I'm so ignorant that, I just wouldn't know where to start. I wouldn't know where to start going. So capabilities are socially shaped, and I think those illustrations from some of those quotes illustrated how patients, when we're transplanted into different healthcare situations, our usual capabilities might be moderated. Capabilities to speak up. So I think what capabilities thinking really encourages us to focus on in this kind of context is that we shouldn't be just focusing on what the individual out there has as capabilities, if they're intrinsic properties that they can acquire, have and use wherever. We really need to be paying attention to the broad range of ways in which what health services and staff do and how they interact with patients can really affect patients' ability to speak up, for example, and contribute to their care. And I think, so I'm just going to float that out and leave it there for now, but capabilities thinking, that with its emphasis on the social shaping of capabilities, might be useful for teams that are planning to involve patients in efforts to promote their safety. I'm going to rattle on because we did want to ask a little bit of time, leave a little bit of time for discussion. And we said in the brochure that we would encourage thinking about how might we assess how well services involve patients in efforts to promote safety. And I think that the main message is going to be, don't worry about all of these things. I think they are relevant, but that we need to be attending to the broader context. It's not just the safety culture and whether there are posters encouraging explicitly people to speak up and get involved. We need to be looking at a broader range of ways in which services generally support and enable people to get involved in their care. And I think for us, the key take-home points that we wanted to leave you with are that patients' capabilities to be involved and to contribute are, as I've just said, variable, dynamic, they are shaped by people's health conditions, so they can be moderated by how ill you feel, but they're best understood not just as individual attributes, but as things that health services themselves shape and influence. And that, going back to that, reminding you of the first half where we talked about involvement in decision making, that relational understandings of autonomy can help us differentiate between more and less appropriate forms of clinician support for patient involvement by encouraging us to attend to how does what clinicians do affect people's capabilities to be their own person, shape their own lives. Does their support help that, or does it hinder that, rather than focusing on autonomous choice? That point, I think we say, gosh, thank you very much for listening to us, because we hadn't anticipated we would take so long to rattle through all that. We do have, I know it's nearly home time, but we would like to give you a bit of an opportunity to engage in some discussion, come back with further comments. I know there are some that we didn't pick up from earlier. Ian and I can also hang around for a bit afterwards if people want to see us individually. But are there any comments, questions, challenges, corrections, criticisms people would like to make collectively? Sorry, that came a bit abruptly, so you might not have. Yeah, I'll do my leap off the stage trick now.
Thank you. I'm Gordon Caldwell from Worthing on the south coast of England. I think we have, certainly in the UK, a big problem with thinking that patients don't even have the right to look at their own notes. I was trying to encourage patients on my ward to look at the drug chart and see whether they could read it themselves, because if they couldn't read it, then a nurse couldn't read it, therefore it's dangerous. And the project fell down because the nurses didn't believe that the patients had the right to look at their own drug chart even.
Is that a common experience, or has anyone got...
In Denmark, they've had the right for 20 years. Everybody knows that. I mean, you have the same in the UK.
Yeah. There's a difference between so there's a difference between a formal right and what people are actually able to do. And even if you have a right and the drug charts are quite complicated, they're, if they're difficult for nurses, they're difficult for most patients. A right isn't going to be enacted presumably until both you've got a change of attitudes of among nursing staff and a redesign of the drug charts. Oh, yeah. Any other? Yeah.
Hi, Belinda Ray Johnson, New Zealand. I guess just to add another layer of complexity to this, what we have in New Zealand is a large proportion of population with an entirely different worldview, and even entering into these sort of conversations about decision making would be difficult without trust in the person that you're having it with, and an understanding of that worldview, and your entire family and extended family present as well. And those decisions wouldn't necessarily be made on the basis of clinical things anyway. They'd be more about how that will impact on your ability to be with your family in whatever context that is.
I think that's a really helpful point, and that the notion of the importance of trust, which, if you think about that model of the focusing on respect for autonomous choices, kind of doesn't really accommodate the importance of trust. And what the relational accounts would better allow you to do would be to say, okay, to enable people with a different worldview to be involved with me, a clinician with a different worldview, in making a decision, I'm going to have to invest in support that's about relationship building. And I might have to be influential in some ways, but that investment in the relationship can matter because it can be enabling. Yeah, really good. Thank you.
So, thank you very much. I'm a physician and hospital administrator, and to me, as a physician, talking to the patient and trying to explain everything as best as possible obviously makes everything subsequently go better. So I guess my question is then, because in this conference we're talking about lean a lot, and we're talking about how to save time and money. Yeah. Are there any data so I'm a big believer in doing this, but how can I sell this to my physicians? Because they always complain that there is no time, as probably the audience recognizes. So are there any data to help us with this argument?
Not an area I know too much about in terms of the overall research, but I am aware that there are some pieces of research that show that this approach of taking time to discuss with people in more detail, take a more patient-centered approach, does take a little bit more time, but not that much more time. It's at the margin. And when you think of the potential benefits, and again, these are all sort of research questions that are certainly measurable to some extent at least, but when you think of the potential savings and the potential benefits, then maybe that time makes a good adjustment. I mean, in terms of the scenario that I outlined about Mr. A himself is fictional, but it does reflect one or two cases that I've seen in my own clinical workload as a GP recently, where people have been to see a consultant and have felt abandoned by that consultant because of the consultant's reluctance to actually support them in the decision. The options have been outlined, but it's been left with the patient. And the patient has then come to see me as a GP, taking up an extra consultation because they have been extremely anxious and extremely stressed by being faced by what for them has been a very difficult decision. And often the frustration for me is that as a GP, I may not be the best person to help advise them or support them because that's the specialist who has the knowledge.
Sure. If I might just briefly comment on that. So I guess my worry is, or my concern is, how can we proceed? So this, I totally agree with you, but my question is, how can we proceed to find ways to investigate this, to get data, so that we can actually sell? I'm sure this is true, but how can we sell our physicians this?
I think there's also something about making a case for what is right. You know, when we looked at those two general principles at the beginning, justifications for involvement. One is actually that it's intrinsically the right thing to do, and I think we shouldn't let the drive for looking for improvement in other domains, like the health outcomes that matter to clinicians, completely override considerations of things that are right in their own right. Yeah, there's a lady at the front here who's been waiting a while.
That's 3 questions. If people want to leave, please feel free.
Yeah.
After those 3 questions, we'll make you stay around.
I really just wanted to respond to the previous question, because we've been doing a large-scale project in the United Kingdom with people with diabetes, looking at the cost of involving patients in their decisions and giving them information and working it out. And actually the quality of what you do is immensely improved. But actually when we worked out the cost, because you use different people to do different things and you don't see them when they don't need to be seen, you see them when they do need to be seen and when it's helpful, it actually works out strangely almost identical for cost, but better for effectiveness.
Yes, I'm Haya Wildschut, an obstetrician, gynecologist, and I'm very much involved in informed decision making for prenatal screening. And there was just a question about the time involved, but I changed my way of counseling patients for 180 degrees, because in former days I would inform patients about all the options, the pros, the cons, etc. That took a long time, a lot of talking, and I didn't reach the patient. I do it now the other way around. I ask the patient what they already know. And the patients know a lot, very much. They look at internet and they see all the options, etc. So I'm even faster now, because I can correct them where they are wrong. And there are only very limited patients who know very little. So probably this Mr. A already knows that he wants to have surgery. 2 minutes job. Thank you.
Also a comment about how we can show these things. I'm from Denmark, and we have a hospital there where we have tried inviting people after surgery a fortnight after, and the number of complaints have decreased significantly. And that's well, it is rather banal, but it has shown very effective.
Thank you.
Thank you.
Well, thank you everybody for all your comments, and thank you. But I think for the sake of the plenary, we better finish now. But if anybody does want to have any further questions, Vikki and I will stay around for a few minutes. Thank you.
It's very bright under that light.
Hello. Just saying your job is